Hello friends, welcome to my YouTube channel TNC Updates. In this channel, we will learn about various current topics and commonly encountered clinical situations. Before starting, the video touches various important topics of critical care medicine and toxicology. The videos are not exhaustive account of the disease conditions discussed. The videos derive their content from various standard textbooks of medicine, critical care, toxicology. But as the guidelines change rapidly, as per the new level of evidence, the viewers are strictly advised to follow the discretion and advice of treating specialists. Before starting the topic, let us try to answer the question related with today's topic. The question is, which of the following statements is false about direct acting oral anticoagulants? Number 1. Prothrombin time and APTT can be used routinely to adjust their doses. Number 2. In comparison to warfarin, the chances of fatal intracranial bleeding are clearly lower with DOACs. Number 3. Hemodialysis may be used to remove active dabigatran from circulation. Number 4. Antidote can reverse the anticoagulant effect of APIXABAN and RIVAROXABAN within minutes of its administration. If you are able to answer this question very easily after listening to today's talk, then the talk is very successful. So let's start about today's topic. DOACs, direct acting oral anticoagulants. DOACs are acted directly to inhibit the clotting factors, basically factors 2 and factor 10. They have emerged as primary substitutes to the vitamin K antagonists. They are typically used in the long-term anticoagulation of patients with venous thromboembolisms, pulmonary embolisms, or non-valvular atrial fibrillation. Some members are used in acute care of patients with VTE and the secondary prevention pathways after an acute coronary events. They offer perioperative practice window to transition from a period of anticoagulation, a safe cessation for procedure-specific risks, and smooth transition to resumption soon after without the need for bridging pathways. Heparin and heparin analogues, vitamin K antagonists, have always been the mainstay of anticoagulation for quite some time now. Their limitation is that parenteral use. Vitamin K antagonist management is again complicated by a narrow therapeutic index, variability in drug action, secondary to genetic, dietary, and other drug interactions. Their use warrant close periodic monitoring. In Indian setups, the major disadvantage of DOACs is only their high cost. So we hope they will become more common in use with reduction of their cost in very near future. Let us discuss three very commonly prescribed DOACs today. Number 1, dabigatran. Number 2, rivaroxaban. Number 3, apixaban. Dabigatran was the first oral anticoagulant which received approval from FDA. It inhibits thrombin from converting fibrinogen into fibrin monomers. Its inhibition of thrombin also naturally entails it blocking thrombin-mediated events such as degradation of fibrin, activation of factors 5, 8, 9, 13, and platelet aggregation. Poor oral absorption, despite the pro-drug strategy, low levels of metabolism in the liver, and a very high renal clearance. In fact, more than 80% of the drug. Gastrointestinal absorption mediated by P-glycoprotein and inducers, for example rifampicin, carbamazepine, decrease drug uptake. Conversely, inhibitors like amidron clarithromycin, verapamil increase dabigatran exposure. Dabigatran is contraindicated in individuals with creatinine clearance less than 30 ml per minute. So the dose has to be decreased as per the creatinine clearance. It has an antidote, idrucizumab, a monoclonal antibody, can completely reverse the anticoagulation effects within minutes. Then the other class is, in general, factor 10A inhibitors. In this class, we have easily available RIVAROXABAN and APIXABAN. In India, we don't have as yet edoxaban and batrixaban. So factor 10A is part of prothrombinase complex, and its inactivation prevents fibrin formation and inactivates platelets. Therefore, all these medications will automatically increase prothrombin time and even APTT. Rivaroxaban, the drug is unique that it has approval in some jurisdictions for secondary prevention after an acute coronary syndrome. Unlike any of the other DOACs, the drug is well absorbed, highly protein bound to albumin. Plasma half-life 5 to 9 hours, prolonged in elderly and in renal failure. It is metabolized by cytochrome P450 system, and gastrointestinal uptake is modulated by P-glycoproteins. Drugs such as ketoconazole inhibit P-glycoprotein and cytochrome P450 system will increase its toxicity. Apixaban, slower gastrointestinal uptake profile compared to dabigatran and rivaroxaban. In fact, in Indian setups, we have dabigatran and rivaroxaban basically. Apixaban is very less. If a patient has any of the following two characters, more than 80 years, creatinine more than 1.5, weight less than 60 kg, then the dose should not exceed 2.5 mg BD. Patients with advanced liver failure should not receive apixaban. So what are the uses basically of all these DOACs? They are used for as an initial therapy of DVT pulmonary embolism, number one. Number two, prevention of DVT and pulmonary embolism. Number three, prevention of thromboembolisms in major hip or knee surgeries. Number four, stroke prevention in non-valvular atrial fibrillation. And number five, rivaroxaban has also received approval in Europe for secondary prevention after ACS. Important points are, in cancer-associated DVT, pulmonary embolism, low molecular weight heparins receive preference over these DOACs. In clinical situations such as end-stage renal disease, warfarin, that is vitamin K antagonist, might still be preferred. Low molecular weight heparins are usually the preferred agents for liver disease patients when anticoagulation is required. In the setting of pregnancy again, we rely on low molecular weight heparins. So what is the dose in various clinical situations? So if we go to dabigatran first, the most commonly used DOAC. So if we talk about prophylactic dose after say THR and TKR, dose can be 220 mg OD or 150 mg OD in patients more than 75 years or with creatinine clearance less than 50. First dose can be given 1 to 4 hours after surgery. If we talk about treatment of VTE and long-term therapy for the next 3 to 6 months, then what is the dose and what are the criteria in case of dabigatran? Initially, as a treatment part, we have to go to low molecular weight heparins or even fondaparinux, usually for the first line for 5 days. Then thereafter we start dabigatran 150 mg BD or 110 mg more than 80 years or high bleeding risk, or some concomitant drugs are also going on. Then as a third Prevention of stroke or systemic embolism in patients with non-valvular atrial fibrillation. The dose is 150 mg BD and 110 mg BD for the high risk groups. If we come to rivaroxaban, as a prophylactic dose, the dose is 10 mg OD. And the first dose 6 to 10 hours after the surgery, given for 2 weeks after TKR and 5 weeks after THR. If we talk about treatment of embolisms and rivaroxaban is to be used, then 15 mg BD for 3 weeks, then shift to OD dose 20 mg for 3 to 6 months. 15 mg if creatinine clearance is on the lower side. So if we talk about prevention of stroke or systemic embolisms in non-valvular AF, then 15 mg BD for 3 weeks, then 20 mg OD for 3 to 6 months. APIXABAN doses, prophylactic dose 2.5 mg BD, first dose after 12 to 24 hours, given for 2 weeks and in TKR and 5 weeks in THR. If we talk of treatment of embolisms, then 10 mg BD for 7 days, then 5 mg BD for up to even 6 months. And if we talk about prevention of stroke, 5 mg BD. In acute coronary syndrome, rivaroxaban dose for secondary prevention is on the lower side, 2.5 mg BD. If we compare as vitamin K antagonists and DOACs, first monitoring. In DOACs, no routine monitoring. Variable assay recommendations are there by various societies. Vitamin K antagonists, they have been here for a very long time. Routine monitoring is required using PT. Assay is readily available and it is very much standardized. Safety. DOACs more reliable, consistent drug effect, renal function can affect safety. If we talk about vitamin K antagonists, independent of renal function, but extensive drug-drug diet and other interactions reduce safety. Onset and offset. DOAC rapid onset, relatively quick offset obviate the need for bridging. Whereas vitamin K antagonists, they have a long latency, needs bridging periods before and after index periods. Offset, no specific antidote in most cases because their effect will wane off in a few hours. Only when, if there is some life-threatening bleeding, we need antidotes in DOACs. But in vitamin K antagonists, they are long-acting drugs and offset is possible using FFPs and PTC, that is prothrombin concentrate. Dosing is fixed of DAC as we talked earlier, except for some like renal and other effects, drug interactions. Vitamin K antagonists, there is a wide inter-individual variation. You have to monitor the PT, prothrombin time. Kinetic profiles, DOAC's rapid withdrawal before an intervention and immediate initiation post-procedure is possible. But vitamin K antagonists, they require cessation, they will require bridging because the period is long before you stop. So the patient is predisposed to some maybe cerebrovascular events, so you need bridging by heparins or maybe even with DOAC. And a waiting period before reinitiation. There has to be a waiting period to initiate it again, so produces a safe target level of anticoagulation. So it requires both before and after. There are limitations. The limitation of DOAC at present is its high cost. So vitamin K antagonist cost is low, but safety concerns outweigh economic costs in select group patients. Exclusions cannot be used in valvular atrial fibrillations. Vitamin K antagonists can be used in practically all situations except pregnancy. So timelines for cessation and reinitiation of DOAC in the perioperative period. So here there are two classes: when the bleeding risk is low and the bleeding risk is high, time to stop before and time to stop in high risk groups. And here time to reinitiate: bleeding risk low, bleeding risk high. So dabigatran you have to stop in low bleeding risk groups and with normal creatinine clearance almost around 24 hours, just 24 hours prior, and in high risk groups where the bleeding risk is high, say 48 to 72 hours, and in low risk groups you start after 24 hours, and in high risk groups you start after 48 to 72 hours. Rivaroxaban similarly in patients who are low risk with normal renal clearance functions, you can stop just 24 hours before and start again 48 to 72 hours in high risk groups. Stop in 48 to 72 hours in high groups, and to start again just 24 hours later you can start rivaroxaban, and in high risk groups you start in 48 to 72 hours. Apixaban again 24 hours you have to stop before, and in high risk groups stop 48 hours before and initiate within 24 hours, high risk 48 to 72 hours. So for central neuraxial blocks, the guideline says that dabigatran is to be stopped 5 days before, and you can start after the lumbar puncture epidural 6 hours after, and rivaroxaban and apixaban 3 days before. So in these 5 days that you are getting, it is a prolonged period if you are trying to plan a regional anesthesia. So you are planning 5 days before, so you have to have some bridging with a heparin in these cases only for DOACs. So lab monitoring of DOCs, as such they don't require monitoring. However, monitoring might be required to determine residual drug effect in some situations like emergency reversal pending major surgery or gastrointestinal bleeding. Prothrombin time is not sensitive to dabigatran, is generally more sensitive to rivaroxaban among the factor 10A inhibitors, but a normal prothrombin time doesn't rule out their presence. The APTT conversely is not sensitive to factor 10A inhibitors but is altered by dabigatran. A normal thrombin time virtually rules out any presence of dabigatran. Anti-factor 10A assays have been used to map the use of rivaroxaban and apixaban in addition to prothrombin time, although guidance from different bodies differ. So, bridging strategies. It is not common to find patients on a DOAC being bridged routinely in the perioperative period, and that heparin bridging increases the incidence of bleeding events. When DOCs are held for 2 half-life intervals, then no bridging is required. When held longer, for a 5 half-life period, as in American Society of Regional Anesthesia Practice Advisory, it is typical to use low molecular weight heparins as a bridge. Emergency hemostatic management in a patient on DOAC. Idrosizumab, a monoclonal antibody fragment, is effective in antagonizing dabigatran rapidly and effectively. Andexinet alpha antagonizes factor 10A inhibitors, that is rivaroxaban and apixaban. Empirical measures like tranexamic acid, FFP, PTCs can be used. Activated charcoal can retard the absorption of most of the DOACs. Hemodialysis can remove dabigatran but not rivaroxaban. Siraprantag, a universal antidote for all DOACs, is in the development phase. Thank you everyone.